we have many missionary on the program here. So I was one there. Missionary Dr. Caroline Betty. We're going to ask her to come and make her presentation. Praise the Lord Jesus. At this time, we're going to ask you to just stand for a little while. Put your hands together for her as she comes forth. Amen, 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 amen.
A women, a women, a women, a women, a women. I'm just messing with you. Amen, amen. God bless you all. You can be seated. You can be seated. Yeah. It's good to be here. I love to give these talks. It's funny. I'm actually a obstetrician gynecologist, and somehow I have given a lot of these prostate cancer talks to different churches. For some reason, the men asked me to to give that presentation. Really, it's the urologist's field, but we all get training in all the areas. So, we can talk on it and so on. And it's quite a significant problem in the Caribbean, especially among black men, you know. And for some reason, you're more likely to get the more aggressive types of it too in the black population. Not to say everybody who gets it gets the aggressive type, but the more aggressive types is more common in the black population. Don't know why. Same thing with breast cancer. Same thing with colon cancer. You know? So it really bears that you should really try and take care of yourself, you know, so that these things don't reach you. Tell your friends, have a talk. I'm hoping by the time I'm finished with the talk, you become an evangelist, just like when the Lord went and delivered the one woman of Samaria or the one man possessed, and then they went out and evangelized. I hope that you will be evangelists of prostate cancer screening when I'm done with the presentation. All right, you can go to the next slide. Next slide. Okay, thank you. What is the prostate that we hear of so much? First of all, I'm going to try and be very interactive because, I don't want to be talking at you, just talking at you, so I want you to talk back to me. So, question, which gender of persons is the prostate in? Which gender is the prostate in? Thank you. You don't hear me say gender, man. It's in men, so it's not in women, right? We do not have a prostate, okay? And what is this prostate gland? So it's a small gland, about probably this size. It is described as a walnut. We don't really have walnuts in Jamaica, but it's walnut shaped in that it has two halves to it and a groove in the middle. All right? So it's kind of almost like a butterfly. All right? And it has a groove right down the middle of it. And it produces fluid. And it also produces what we call enzymes. And it nourishes the sperm. Bathes it, like you probably go to a spa. That would be a spa tree. Just get a nice wash. Just wash it. Right? And the fluid that it produces helps to move the sperm along. Next slide. Next slide. Okay, good. For a minute, there was one there, the person fell asleep. All right, so this is a simplistic view of the entire male reproductive system. All right, let me see. You know what I'm gonna do? I am gonna ask each person until we complete it about what you see. So, Bishop Griffiths, tell me one organ that you see there.
Penis.
All right. So the penis is what is used for reproduction on the male side. All right? It is used for intercourse, and that is how the sperm gets to the female. Elder Barif, tell me something you see.
The bladder.
Okay, so the bladder stores the urine, and the urine comes from the bladder, comes through that long yellow tube, and comes down into the penis. Please make note of that. Your turn.
Yes, sir. That is the balls.
Balls. Testes is the terminology. But yes, I accept balls because you know what you're saying. So the blue thing is the testes or the testicle. That is where the sperm is made. That's where you make your sperm. All right? All right. And what is the testes in? Let me see if somebody can tell me, anybody at all. What is the testes located in? Man, let me say right. The scrotum, very important. That is very important. And the scrotum is made of skin. And unlike the women, the men, reproductive, the testes hang outside of the body, right? That's what stores the sperm. We have our eggs inside. You have to have your sperm outside because your body is way too hot to accommodate it on the inside. So if it's on the inside, they would not survive. Because they hang down, it's cooler on the outside. Which is why we don't advise you to wear like tight briefs, because it compresses it. You want it to hang loose. Boxes are actually better. Okay? And for persons who do like heavy machinery work where they sit on the tractors and the heat is coming from the engine, they tend sometimes to have low sperm count to no sperm count. So you have to be careful with heat coming to that area at all, right? Okay. All right. Anything else? You see, I'm going to come to you. What am I talking about today?
All right, the main thing I see, ejaculatory duct.
All right. The ejaculatory duct connects to what we call the epididymis, all right? Which is that long yellow tube. Now, I made mention of it because that long yellow tube is how you get your urine out. That long yellow tube is also how you get your sperm out. So both of them not supposed to come out together. Is either one or the other. So when a man is sexually excited and is about to ejaculate, the area that the urine will come from gets closed off so the semen can come out. All right? It's like trying to breathe and swallow at the same time. Try to take a deep breath and swallow at the same time. Try it right now. Can you do it? Your body stops you. It's not you do it, you know. That is because you have a little thing that we call the pharynx that goes this way, that way. The glottis. The glottis goes this way, that way. And that's why sometimes now, if it's in the middle, and you ever see a baby and things come out of the nose, go in the mouth, come out of the nose, it's in the middle, it's a little floppy. So the connection is a little more open so it comes out, right? But you usually can only do one or the other. So it's the same thing with urine and sperm. You can only do one or the other. All right, now, I need somebody to tell me what I'm talking about today. Prostate, right? Nobody don't tell me about the prostate. Imagine that prostate, everybody say everything about the prostate. Yeah? All right. And of course, you have the prostate. So when the sperm is made in the testes, when it gets mature, it goes into the little purple part, right? It stays there, and then when you get sexually excited, it shoots up the purple tube. It gets some more fluid from the seminal vesicle. It gets the enzymes and stuff from the prostate, and then it goes into the orange tube, and then it shoots out. Yeah, when the Bible says you're faithful, it's true. Right? Okay. So you have an idea of how the system is now. More complex than you thought, eh? What you call the sweet water fructose, the seminal vesicle, the purple thing at the back behind the bladder. Yes, fructose. So yes, you're right. There's sugar in it. Next slide. Okay, so prostate cancer, naming prostate cancer, it's cancer that is found in the prostate. It originates from the prostate. It's one of the most common types of cancer in men, and as I mentioned before, especially in black men, especially those of African descent. So you know that is the entire Caribbean, right? And everybody from the other side of the world that has more black than white. But it can occur in anybody, but it's one of the most common cancers here in men in Jamaica. It's a significant problem, right? Most of them grow slowly, and the advantage of that means they stay in the prostate and they grow. So if you are doing your checks and so forth, chances are for the most part you'll pick it up. If you don't, it grows slowly and then it starts to go outside of the prostate. That's when you have problems. All right? Because then it starts to spread to everywhere else it can go. But when it's in the prostate, it can be treated quickly and more effectively than when it actually starts to spread outside. All right? Next slide. So as I mentioned before, some grow slow and they're not as aggressive and they may need no treatment or minimal treatment, and then you have others that they just come out and they decide to bust a fight on your body. And those ones grow quickly and they move through your body quickly. Next slide. So there are 29 types of prostate cancer. The reason for that is the prostate itself is pretty complex and it has several components to it. It has different type of cells, and all those different types of cells can have different types of cancer forming from them. You understand? So that is why you have all these different types. But again, if it's in the gland and it hasn't spread, you can treat well. And as I mentioned earlier, it's really the purview of the urologist. So a urologist is like a male gynecologist. That is your gynecologist, to put it in that way. That's the person you're supposed to go and do your checks and so on. And then the thing about it is, even if you don't get prostate cancer, for the most part, the older you get, the bigger it gets, which is why you find a lot of men having problems passing the urine and all kind of other issues, or they pass in the urine more frequently or so. So even if you don't have the cancer, you might have enlargement. Sometimes it's so bad that you can't pee at all, and we have to put a catheter in. All right, so either way, you really need to go get checked out by your urologist. Next slide. Okay, so I would like to know at this point, what are the men thinking? Feel free to speak out. What is in your mind at this point of the presentation?
Yes, Doc. What I would like to know, you can do a blood test, right?
Oh, we haven't reached there so yet.
Okay, okay. That's
Just what
to
I've
ask.
spoken about so far, what are the thoughts that you're having?
I would like the thought what I have is to do a test, but they say it's too tight. When I looking at the picture, I say, oh, them say, when I test it from your bottom.
All right, so I'm going to go into that. So let me be more general, more specific then. Are you interested, the men that are here now, would you be interested in getting to know what's happening with your prostate at this point? Could you honestly say at this point you would want to go to the doctor and get checked out? How about you?
Yes.
You think so? All right. Next slide. So here's the thing about this now. One of the things that we talk about is symptoms. How do you know that you may have this thing? How do you know that it might be happening to you? Now, here is the thing with most cancers. When they're in their early stage, they don't show any sign. You don't see anything happening, which is the purpose of screening. A screening test is a test that you do in a population that is at risk for something before the disease occurs. So the only true screening test I can think of us having is pap smears, because that one actually you can catch the abnormal cells before they progress to the cancer. The other screening tests that we do for the other cancers, usually we find an abnormal cell already, the cancer cell, right? Yes, Elder.
Suggest that, whether male or female, they do a checkup with your physician or your doctor, whatever.
You better do your checkups, yes. And when you reach certain age, you need to do it, which I'm going to discuss. Now, when it's advanced and it starts to cause problems, chances are you're in a bag of problem already, right? When you start to see blood coming in your urine, or you're probably having problem passing your pee-pee, or it's not coming out as strong, chances are you're in trouble already, all right? How bad of a trouble? You don't know, okay? Next slide. You can also have blood in the ejaculate. You ejaculate and you see blood in it. Pain in your bone. If that is the case, then it has actually spread. You're losing weight, which is a common thing for most cancers. You know, sometimes you spend so much time trying to lose weight because you pack on the weight at certain points in your life. Then these things make you start to drop weight, but not in a way that you would like. You know? And erectile dysfunction. But the thing with erectile dysfunction, oh, by the way, what is erectile dysfunction? If you know, put up your hand. There is no way Uno don't know what erectile dysfunction. Somebody in here must know what erectile dysfunction is. All right, you see, I want this gentleman to answer the question. You're going to tell everybody what is erectile dysfunction. Preach it, brother.
Bless the Lord, everyone.
Bless the Lord.
My belief about erectile dysfunction is that you're not performing well. The married men are not performing well with their wife as they used to in their younger days. You find you won't wake up with an erection that's strong in the morning. Because all young men should know that most of us wake up with an erection in the morning. When you find that start to decrease, or none at all, you know that something is wrong.
Thank you kindly. Thank you kindly. It's all balling out around there. I saw two other persons put up their hand. So I'm going to ask for their definition of erectile dysfunction. Your definition of erectile dysfunction, Elder.
Well, it's just that you will, when you're performing, that means you're having sex with a woman. And you normally before you ejaculate, maybe normally on the normal, for you or personally, maybe you could go 15 or 20 or half an hour, and then you start to decrease. So within a 5-minute span, you're not able to go over that.
Okay.
I always talk to older folks, elder man like father figure. Sometimes I say, sometimes I'm a prostate, you know, brother. What at the age and we get old, so we know this so again.
Okay.
So
That's what you see it as.
Yeah.
I was just only saying that
Talk into the mic.
I was just only saying that I've only been hearing that it's in older folks, but I believe that even young people can have erectile dysfunction.
Okay, I don't know why she acting so shy. She's saying that she has heard them saying here for this discussion older men, but she knows that young men can have erectile dysfunction as well, which is correct. All right, but what you're saying is correct. Basically, erect means upright, standing. All right, that is when you have. I know you want to say something. All right.
Bless everyone. I believe according to how you feed your body. If you're not feed your body properly, believe me, you will.
Okay.
Question, Doc. Is there any relationship between prostate cancer and stoppage of water? I'm a whole man and maybe the oldest person in the group here today. First time I used to heard about stoppage of water. I'm not hearing more about it again. Is there any relationship between stoppage of water and prostate cancer?
Okay. I want to answer your question, but I'm going to complete what I was saying about erectile dysfunction. So, erect means upright, stand, firm, right? Which is what happens to the penis when the male is sexually excited because blood flows into a very strong vein. If you ever look at your penis when it's standing, you notice that a vein is very, very prominent. So, that vein supplies blood supply. Inside of the penis, there's a lot of spongy tissues, what we call sponge. So, you know, like how water can take up a sponge? That's how the blood rushes into it, and then it becomes so engorged and full, it stands. All right? Now, what erectile dysfunction means simply is that that does not happen like it should. So you may have what we call a flaccid penis, or it's flopping, it's not as firm. And also, it means that even if you have it, it might not last as long, which might not be related to anxiety, which can happen, but you're not able to perform like you should. Now, have you ever heard of the blue pill? All right? That's one of the pills. There are several different types that we have on the market, and we're getting better at producing stuff that works better for men. Because the blue pill actually causes that very same vessel I told you about to relax and dilate. So the blood rushes in. However, let us say somebody has high blood pressure and that blue pill does what it's supposed to do. All the blood floods to there and the man's pressure drops and he blacks out. Because it's not happening as natural as you naturally would have it happen. So you find that we don't really want them to use it, or it interacts with their medication. Or they realize when they take the medication, it doesn't stand as well. So sometimes one of the problems we have is that men do not take their medication when they're hypertensive because hair gets affected. All right? And sometimes it also causes it to stand for so long because it's not natural. It's there lasting, take a while to go down, you know. But it can be good and bad. The whole point though is if you find that you have to use that, then you really should ask for your doctor's advice. Because a lot of men have died that way. Well, them die happy because they die standing. But they die.
I've heard about this phenomenon, for quite some time now, since I was young. So why is it a bad thing and why can a person die from that? An extended erection.
Your blood flow is all here. It's nowhere else in your body. Most of it is here. So your heart gets attacked. Your brain not getting blood flow. Because most of the blood is down here.
The normal circumstances isn't the same.
No, that's the point I was making. It's not a normal erection. It's an aided erection. So The thing about it is, what I'm saying is, if you have other issues in the body, which a lot of men tend to do at the age they have this problem, if you're going to use that, ask for medical direction, because if you don't, it might just take you out. You understand? But the newer drugs that they're making actually is working a little better. To address your question now, that's what I was saying earlier, Bishop, right? That even if you don't get prostate cancer, the prostate gets bigger as you get older. And if you can remember where the prostate was, remember that the tube was passing through it for it to give the fluid. It closes on that tube, so the water from the bladder cannot come down. Right? That's how it works. So the cancer can make it bigger in that it's a bigger gland, or the cancer can actually go into the walls of that tube and block it. So it can physically block it or structurally block it. All right? And then you find that those people are the ones that have problems passing the urine. But passing the urine with issues doesn't mean you have prostate cancer. It doesn't mean you have a big prostate. It can be a lot of other things. But it's just that that's something that you can have. Does that answer your question? All right. Stoppage of water means you can't pee-pee. That's what it means. No, it still happens. It still happens. Okay. All right. So the cause of prostate cancer, we don't fully understand the cause, but we know things that can lead to it, right? And at the base of that is that a cell is a nice big round thing. If you can just imagine a nice big round thing. All right, think of a fried egg, right? So you know you have the yolk in the middle, and then you have the white thing going around, so that is your cell. In the yellow part is the DNA, that's a pulse, that's the knowledge and everything of the cell. Anything that needs to be done is done in that portion of the cell for the main part, because things still happen in the white part, okay? Now your cell is programmed that at a particular point, it is supposed to double up in that yellow part. When the doubling is complete, it is supposed to separate. I think I have some slides like that. Oh, jumped this already. I'm not even finished the other part. But anyway, well, here, yes, there it is. All right? So that's the yellow part. The blue part is the egg yolk, right? And you have doubling up occurring in the part that's called prophase. When they double up, then they march like soldiers on a line, and then the spindles pull them apart. When it pulls them apart, they go left and right, and then you have the cells starting to break down in the middle, and you have two new cells forming. That's normal. Could you go back one slide, please? And thank you for being so proactive. All right. So in there, all the instructions are in the cell that says, you're an eye cell, you're a nose cell, you're a skin cell, you're a prostate cell. This is what you're supposed to do. This is how you're supposed to grow. And the instructions are there. However, what happens with cancer is that something goes very wrong in that area. And it's like your children rebelling and decide they're going to do what they want to do, and they're going to grow where they want to grow. And then the thing is, they start to grow erratic, so they grow faster than they should. They grow out of proportion than they should. And it gets worse. Go to the other slide. You see, you have this as normal. Next slide. What you have happening is that they just grow and grow and grow. And you know what I'm saying about bad company? Them come and whisper something to you. Where you follow that for, like the devil? You know what the Bible say? Where you do that for? Do your own thing. And they start to make the persons around them do their own thing. And they just go and influence the other cell. And then they grow and grow and grow and grow and become unstable. So if you imagine you're stacking building blocks, and you're just stacking them, after a while it becomes unsteady and they break off. So they break off, and when they break off now, they start to go in your bloodstream. And they go into your bloodstream and they lodge on your liver and say, liver cell, what go on? You don't have to do what them tell you to do, you know. You don't have to read the Bible. Do your own thing. Do your own thing. Liver starts to do its own thing. And it becomes unstable there. And it goes to the lungs. I said to the same thing to the lung cell. Lung cell, you have a problem, you know. You understand? So that is what happens in the body. And then now, in addition to saying, okay, you're supposed to form this and you're supposed to, can you go back one? Why are we so far ahead? Go back. Okay, wait, stop. Go to that one actually. Go to that one. All right, so you see what's happening? This is what I'm describing. Now, under normal conditions, with your cells forming two from one, your body has a program that says when you reach this point, just like we have an appointment with death, you're dead. So the cell knows at a certain point it's supposed to die. These cells are immortal. They do not die. They just grow and grow and grow, and they consume everything. So it's like you have your house, and some people move in, and they bring their relative, and feed their relative, feed their friend, and feed their friend, come in, and everybody pack up in there, and the food done, and you can't support everybody, and the light cut off, and the water cut off, and everything, and that is how you actually end up dying, because your body is in it. Program cell that your body normally has is not in these cells, so they just keep on growing and growing and growing until they have to move all over the place and take over your body, and you can't take it. Go back one for me, please. So when they do that, they start nearby, then they go into your bloodstream, then they go into your lymphatic tissues, then they take over your body, and that is what we call metastasis. So when you hear somebody say the cancer has metastasized or spread, that's what that is. Okay, forward. And forward. All right, so there is a question now, Bishop. Look where the prostate is. It's right under the bladder. So that red thing you see, above it is the bladder. Notice it is actually surrounding the urethra, which is coming from the bladder, which goes out into the penis. So if you have anything happening at the level of the prostate, it's going to affect that tube. And that tube being blocked, you get your stoppage of water. That's what they call that, right? Okay. So the point I'm making is, though, that you can have a blockade along the whole length of the tube. So depending on where the blockage is, that determines what is causing the stoppage of water. All right? But with the cancer, or if the gland itself becomes bigger than it should be, it will start to squeeze on the tube. Or you find that the valve that's there is affecting it, so you have to go really quickly, or you can't hold your pee, depending on how the obstruction is. All right? So the bottom slide show you what a normal prostate looks like. Remember, I say it's a walnut, it's like two halves, and then you have a groove down the middle. So that is how it looks. All right? And then the cancer will start where you see that yellow thing, for instance, and it start to take distorted shapes, and then it spreads. So this is actually within the gland. It hasn't come outside of it yet. So when we're doing a check, this is what we're feeling for. All right? When we do that check that I'm going to tell you about, and we insert our finger into the anus to the rectum, we're feeling the groove. Because the groove is where a lot of things start. We feel it. It's normally nice and smooth. It has a little dent. It's not rough. We're not feeling anything weird. So we're feeling to see if we feel that it feels irregular, if it's not present, if we're feeling some rough, bumpy stuff there, then we know that something is off. All right? We can also get a feel of the rest of the prostate to see if it feels within the size that it should be as well. Next slide. Okay, so risk factors. I have some here, but I want to see if you can probably guess, apart from what's obvious on there. I'm going to start with the leader again. You can't answer that one because I wanted it on the slide. What do you think are risk factors leading to prostate cancer? Just tell me one.
You know, I can respond to that question though.
Okay, fine. Eldo, take a guess. Risk factor.
Well, I may say the same. Look.
All right, does anybody in here have any idea?
Can I say like less sex?
No. Thankfully. So you can stay as celibate as you want. The monks don't have higher risk of prostate cancer.
Versus when at what age?
It's up there.
About 40 years.
It's already up there. And no, that's not a risk factor. I'm going to tell you what that is.
Infections.
No, not really. There's a very, very easy one that you can catch.
Your skin color.
No, not really. Anybody else want to try? You want to try? All right. So you can't really answer the question. Change your mind. Okay, go.
I was really thinking of body cells.
No.
Because, okay.
I'm going to go to the educator in the group, one of the educators in the group. I want you to hazard a guess, Rev.
Genes, genetics.
Ah, that's why I come to the teacher. I tell you, it's an easy one. It's in your family. It runs in your family. That's a risk. That's a risk you have. You know, I was thinking that you know, you'd probably guess that one. Yeah, no. I'm saying I was hoping that, you know, they would guess that, you know, it's in your family, you know. But, okay, so we're going to go through risk factors. Older age, why you think that is? And you can speak up. The older you get, the more likely you are to have a cancer. Why is that? Because the older you get, the more likely your cells are to malfunction. Just like how you get old, your limbs don't work as well, your body don't work as well. It's the same thing. All right? Go ahead. Yeah, you can be my roving microphone. It's on.
He said because he was wild. He love the girl them. I just tell you what him say.
Yeah, no,
Him say
not
that
really.
cause it. Him have a whole heap of picnic, love the sex thing, and him not have no control over the sex thing.
No.
So
give
disabuse
me
that.
Right, because, I mean, you think of men like Solomon and David, I don't believe they had prostate cancer. All right? And you can have men with multiple wives, they're more likely to have a sexually transmitted infection. And that causes a different set of problems. So there's age, and it's most common after age 50, which is middle age, kind of, sort of ish, yes. Because we have what, 3 score and 10? So it's probably a little over middle age, but a lot of people can, well, not a lot, some people go to 100. So we'd say 50 is in the middle. Next slide. Hello? Hello? Thank you. Good. Race. So not skin color. Right? That's what I said. No. If you had said race. Right? Okay, so as I mentioned before, the black people are more likely, but it doesn't mean that the white persons cannot get it. All right? Next slide. Family history. And I'm going to open that out a little bit now. So the family history is not only in the male, it's also in the female side. Okay? So if you have women in your family that have certain kinds of genes, it's likely that that gene is in the male side as well. So we have the genes that we call BRCA. BRCA1, BRCA2, breast, colon. Right? So you're more likely to have breast cancer in the family. You're more likely to have colon cancer in the family. You're more likely to have prostate cancer in the same family if you have that abnormal gene. Now, there is an actress by the name of Angelina Jolie. Do you know that name? Yes. All right, very beautiful woman. So she had a very strong history of these genes in her family. All of the women that were before her died in their 40s, including her mother, 40s, early 50s. And then she got herself tested and realized she had the gene. So what she did, she had her kids, finished having her children, and she did what we call prophylactic mastectomy, which means you take off the breast before nothing do it. Prophylaxis means you do something before it happens to prevent it from happening. All right? So she took off the breasts, and she also had her ovaries removed. All right? So she is still alive, because she probably would be dead by now, because it seems to be a very aggressive form there, you know? So it's the same thing. You can get tested if your mother, somebody related to you, your child, whatever, if you have this gene, okay? And you can do it even if you don't have anybody in your family that has it, if you want to know the family has the gene. It doesn't mean you have the gene, you have to get it. It's just that you're more at risk, okay? Next slide. Obesity. For some reason, what I believe, though, the link to that is fat cells, they actually have hormones in them. That is why some people who are obese have problems with their periods, the women, because the fat cells have hormones in them, and they tend to have male type hormone in them. The precursor to testosterone, let me say that again. The hormone that leads to the formation of testosterone, androgen. Right? So fat cells have androgen in them. So you'll find that these women, for instance, who have the problems with their periods, they have a lot of androgen. And some of them might be more hairy, some of them might be fat, some might be skinny. So it depends on what you have. So in the male side, when you're obese, you have more androgen, and for some reason, that causes more risk of prostate cancer, and it's more likely to be more aggressive in the fatter people, the fatter men, and more likely to be resistant to your treatment in the more obese person. For one, you have to give more treatment, because when you're obese, well, we weigh you when we're giving you like chemotherapy and so. So it depends on your weight, and we give you the drug to match your weight. So there will be more drug that we have to give you the bigger you are. You understand? So you find that it might be a little bit more of a challenge to treat than persons who have healthier weights. All right? Next slide. All right. So it was last year, the urologists did another presentation on prostate cancer. Right? And they discovered that anywhere in the island of Jamaica that there's cadmium or bauxite, persons are more likely to have cancer who come from those parishes. So at the top of that was Manchester. So anywhere where you have a lot of bauxite mining occurring, they get a nice cluster of men coming with prostate cancer from that section. All right? So they realized that and they shared that with us. So if you remember in the slide previously, I mentioned that age is a part of the thing. When you're older, and after the age of 50, you're more likely to have it. So what we generally do when it comes to screening is we start screening you 10 years earlier than when you're expected to have something, which is how the 40 comes in. All right? So because we know you're more likely to have it at 50, we start screening you from 40. So since I said that, I'm going to see something. If somebody in your family has had prostate cancer, and they had prostate cancer at the age of 50, let us say 45, how old should they be for you to screen them?
35.
Good. And you would get it. Why did you say 35?
You said they should test for it or screen for it 10 years before they have the potential to be positive for prostate cancer.
That's correct. So with any cancer, anyone that there is a family history of, because not all of them have family history, but this is one that does. You start screening from the age of the youngest person in the family that had it. So if for some reason somebody had that age at 25, it means you're going to have to start screening the rest of them at 15. You understand? So that is how it works. So even though we say 40, if it's in your family and somebody got it before that, you have to go earlier. That works for breast, that works for prostate, that works for colon. Okay? All right. So, well, this was talking about prostate cancer in Jamaica. It was an old test, but the thing is, we do have a high incidence not only in Jamaica, but the entire Caribbean, as I mentioned. So we have problems across the board, and we believe it's because of the African descent that most of us have. I mean, some countries like Trinidad have more Indians, but Tobago has more of the black population. So you'll see it more in that side. Next slide. All right, and prostate cancer accounts for almost a third of all cancers diagnosed in Jamaica. A third, yes. I believe it's probably second to breast cancer. All right, next slide. So the test. This is a reality. This is a real reality. You notice the doctor is gloving up, and where is the man? The man is hiding, the man is behind the bed, and only his nose and eyes showing. So you know that he's actually there. Probably they should have just put his feet there. This is a real thing. I have men in my family that they know they're supposed to go get themselves checked out. They call me, I come in, I come in. I have to say to them some of the time, son, I'm in a God. I must stop telling lie. Because they can't reach all now. 4 or 5 years pass from them coming. Can't reach 6 years, 7 years, 8 years. And every time they see me, I come in, no man, I come in. I come in, I just don't find the time yet. But I come in, I come in. So till the women now start to say you're all a bunch of liars because we went and did our checkup and you refused to go. But this is a real problem that we have, and I believe it has a lot to do with our culture. Because what I explain to people is that we have areas that are called the erogenous zones in male and female, and it is in the area concentrated known as your perineum, which is on the hair, all the way to the butt, front and back. All right? So the whole area can be stimulated. And you have pleasure zones in the anus. Let that just sink in a little bit. You have pleasure zones in the anus. People have forgotten, men and women. You have to get comfortable with the truth. There are pleasure zones there. All right? So, there is something that we call milking the prostate. And let us say a couple is having problems having children, right? And they want to test the semen. Now, how they have to test it, the man has to get it out of his body. Can you imagine how the man can get the semen out of his body? How can the man get it? You personally, how can you get your own semen out of your body as a male? How can you do that? Come on, man, people of God.
Having sex.
No, you're not getting any help. You have to do it on your own. So what do you do?
Masturbation.
All right. So they have to, you get a cup.
I don't think you have to masturbate. I think you can, the doctor have a way to pull out the sperms.
No, darling. That's not how we do it. I ask you how you, when I ask you how the doctor can get it out, I say, how can you? Because I wanted that specific response. You get it? So you have to, a lot of men not comfortable with this thing. Can you imagine? So they give them some magazine to look at, and you look at the magazine. Imagine a man gonna look at all the magazine. I said, this is still unholy. Eh? Let's be there doing this thing and get it in the cup. And then you take the cup for us to test, right? Okay. Let us say you're having some issues because you feel uncomfortable with doing that. You can have a nurse or a doctor come in and assist you, and that's what we call milking the prostate. We put our hand in, we start to massage, and as I said, there are erogenous, erotic, pleasure zones in your anus. So we there, we massage, and it comes out. Now imagine somebody's playing around in your bottom and you realize your penis stand up and semen come out. And you start to wonder, give him the microphone.
Wonder if you're normal.
You're wondering if something wrong with you. No.
Doctor.
Yes,
Tell me
Bishop.
something. Can we improve on how we get it out? Can we not have some female doctor that would just find a way nicely how to get it out than doing that? Or can we find some well, don't have to be a doctor, just find somebody else that can get it out instead of doing that thing.
Yeah, that's how it's done. That's how it's done. You see, he's already uncomfortable with the idea, right? But that's milking the prostate. So, you can be having intercourse with a female and she can stick her finger up your rump and you actually get a stronger ejaculation. I'm just educating you. That's all. I'm just educating you, okay? But this is a fact. It doesn't mean that something is wrong with you. Your body is that way. And if you want to take it up with nobody, take it up with the Creator. He's the one that created you. But I've often said, just a minute, Bishop, that think about it. When you go to the bathroom and you're trying to get the stool out, when it comes out, you feel this because there are erogenous zones in the area. But it doesn't mean that something is wrong with you, all right? So when people say, oh, men enjoy doing certain things, that is why. And you have women that enjoy it too, that is also why. But you can also have damage to the sphincter that holds stool in until you're ready to say go. As you know, when you're born, the stool just comes out, then you learn that you can hold it. So your body learns to hold it. But if you damage that area, then the stool can come out. So people do stuff like that, and there are ways and means of getting around it. But the point I'm making is a lot of men in our culture, because our culture, this is associated with certain things, they do not want to go to the doctor for anybody to be playing up in the bottom and then feel good on top of it. You know? And not understanding.
Doctor, one more question.
No, a lot of men are really traumatized when they do that with a female, and it's a female who knows certain things, and she stick her finger up the rump, man traumatized for life.
Doctor, I did a surgery, took out my appendix, and I went to University of the West Indies. And for that day, the doctors abused me. Big time abuse. There was nothing that felt good or felt sexual. Every one of them that came that came as a counsel, let us test, they did all the training on me. And it affected me for years, you know.
Really?
Yeah, I could not hold my stool.
No. I think you were just traumatized because you just didn't understand what was being done.
I'm telling you, I could not.
And that can be mental. That's what I'm saying to you. Because if you go through something like that,
can I say this to you? It
go
had
ahead.
nothing to do with mental.
All right. So I'm going to ask you, Bishop, since you're describing that, tell me exactly what they did to you, since you're sharing with us.
Put the finger into my rump.
Did they use anything else up there?
No, that's the finger.
Then, although you don't want to accept it, Bishop, that was not why you weren't able to hold your stool.
You know what happened to me? And you got to tell me why.
Okay.
When I went to the bathroom to use my stool, it was all over the toilet.
Okay.
And that happened
So
for
were you
about a
eating
year.
solid food at that time or mostly liquid and soft stuff? Can you remember?
After 2 weeks, I began to eat solid food.
Then that's the reason why you had that issue.
It was because they put in a finger in my rump.
The reason
So
why I asked you the question.
cannot get a doctor to do that again. I'll have to do the blood test and that thing.
Well, this is a perfect example of the problems that we have with the
yeah,
men.
you're going to have a problem.
Because,
God have to touch me.
But Bishop, I'm going to tell you, it was not that, even though you probably don't want to accept it. If you can trust me as a medical professional, if you can trust me as somebody that you knew growing up from I was a child, that you used to carry on your shoulder, if you can trust me that the knowledge that I have gained over the years can make me speak as an expert in the field, I can tell you categorically that is not why you had that problem. It could be any number of reasons, but that was not the reason.
So why homosexual have issue with it, with the stool?
Because it's not the finger that's going up, it's a penis. All right. Seeing as though we're having the discussion and I'm very open to just talking, listen. For the act of anal sex to be safe, the person has to be fully relaxed. Okay? I'm going to explain that to you now. Let us say we're going to jump off prostate for a bit. You have a family history of colon cancer, and you need to do a colonoscopy, right? What they tend to do is take you to an operating theater, and you're given anesthetic so you relax as a person, because you probably wouldn't be able to relax on your own. But when you're relaxed, we have to put a probe. That's why I asked him specifically to tell me what exactly they did. You have to pass a probe, probably about this size, up the anus, right? And there are different types. Some of them are rigid, which means they're firm. Some of them are flexible, so they can navigate through your colon and your intestines, all right? But it has to go up that way. And they pass it up, and they use a camera so we can look. And if anything is abnormal, we take samples. You follow? All right. For the act of intercourse with that, is the same thing. The person has to relax. Now, if you're all excited and you just go wham one time into the anus, you're going to cause some damage. That's how they get damage. You understand? If you do not wait for that, your whole fist can go up there, you know. It's not as flexible as the vagina, because a fist can go up into the vagina as well. All right? They actually call it fisting. People do that. People do stuff like that, okay? I mean, y'all just need to know what's happening in the world. You don't have to participate in it or anything, but you just know. So it doesn't take you as a surprise, or so you're not unlearned in the matter, but you don't have to participate or, in it. But that's the whole thing. Now, if it's relaxed though, then it's all fine. I mean, women can have that problem without even doing anything. If your baby comes out, even if it's a small baby, and the baby is twisting coming out of there, it will actually open the anus, the sphincters there. I've had to repair women's sphincters so that they're able to pass the stool normally after they give birth, because they get what we call a 4th-degree tear, which means it goes down into the anus. And it's a very tricky type of surgery, because if you don't do it properly, they're going to still have the problem. You understand? So that's how that goes. But the thing is, this is not going to be a pleasurable, erotic type of thing. It's a very quick technique. You go in, and we're careful how we go in. We don't just stick up there either. So what we do when we glove our hand, we put the gel on. We actually go in this way, not this way. We go this way and just slide our finger in, up, down the groove, left, right, out. That's it. So it doesn't last long. You're looking at about a minute or two of examination. That's it. But when you're milking the prostate, you're actually in there for a little while doing something else, which is completely different. I just gave you that information for you to understand that. Okay? But because of our culture where men don't want you to put anything up there, it's very difficult to get the men to come in and get tested because for some persons, they may just have that pleasure hit or they just don't think anything should go up their bottom. All right? So that is what we call the digital, this is called a digit. Your fingers are called digits. Digital rectal examination. All right? Next slide. Hold on. Yeah. Go ahead. Take the microphone. What I think happened with, all right, first of all, he said, did they actually remove your appendix? Okay, well, they would have. Even if nothing wrong with it because they don't
It was an appendix, ruptured appendix?
Well, yeah, I'm appendicitis. But one of the routine things that they do before they go into do stuff like that would be a digital rectal. But I believe what happened with our dear bishop was that he was taken aback that this had to be happening to him. And when you're doing that type of surgery, because of where you're going, we usually put you on a liquid diet. You know, we don't want you to be straining or anything like that because you have a cut. And we're going in the area of where those things are. So your stool will come out more and stuff. But he said it affected him for years. And I think he was very traumatized. And the trauma of it all had its own.
And I'm saying that is a pity, and this is where the medical person would have to, probably should have spent some time to explain and to help him emotionally through it. Because how he reacts now, I don't think will help young men with some of the problems they are having, especially this erectile dysfunction. I'm disappointed that women are not here because in my counseling thing is that when their men are not performing or overperforming, it's an issue and the women are not under, worst of all, the men don't know, and the women are not here to understand what, and the medication, hypertensive medication, and other medication, they don't understand why they're underperforming, why them thinking about giving them jacket and waistcoat and do all kind of something to even up with them. I'm very disappointed that the women are not here. It's a men thing, but.
All right. No, when I went to University of the West Indies, I thought the trainees doctors, they came by my bedside a couple times. Well, I think every one of them was training on me. Every one of them that came to my bedside.
That specific examination?
Yeah,
okay.
Most of them did that. If it's 5 of them, they all put their hand in my behind. Okay. And it was not there was no sexual feeling about it. It was painful.
You had inexperienced trainees practicing on you, so that was different. Right. But
before you respond, Doc, Bishop.
Yes.
When because I'm at a certain level, I didn't traumatize myself. Yeah. I was in the University of the Hospital, not even 3 days, and more than 20. It's a training hospital. Dr. Betty helped me. And while I was on my bed, I heard an announcement. I became the subject. And so many junior doctors, because of how my age, what was happening with the multiple strokes I was having, and the results they got from the things that they did, I became a specimen. Everybody, I hear the announcement. So this one is coming now, that one is coming, and I'm saying, Jesus Christ. But because I understood that my body which I did consent after I did. You can take it, but I was alive. And so many junior doctors, old, young, and middle age, were using me as their specimen, the experiment, the guinea pig. And I just allowed it because I figured that because the healing process was in place too, they did not even understand why I was still alive. So I subjected myself because I knew everybody from the islands in Jamaica had my body. I had to stop them at one time and say, right now, I feel unwell. Because so many hands that never have on no gloves were all over me.
Okay, so I'm going to address that. All right, so I don't know why somebody clapping. All right, I'm going to address that specific issue. All right, so first of all, medicine is a hands-on training experience. From you start training to the end of your training, in that the end of the part where you actually graduate, because you train for the rest of your life. You're always learning. For you to know certain things, you have to see what it looks like, know what it feels like, and what the person will experience. It's not like you just sit in a room in mechanics and then the person come and you suddenly know what to do. It doesn't work like that. In addition to that, most of your body is similar, but some people have different variations, and you have to also know that. So let me give you an example. If you should do it yourself, put your thumb and your ring finger together like that. Do that for me. Any hand. Thumb and ring finger. Look here and see if you see something standing in the middle. You see something there? No, you don't? Let me see yours. All right. Stand up, Bishop, because yours is very prominent. I want you to raise your hand up. You notice that there's something prominent in the middle here? Can you see that, everybody? I don't have it. That muscle is what we call the palmaris longus. I don't have one. All right? The thing about that, thank you, is that you have to know things like that, variations of how the blood vessels are in the neck. So if you need to do something in the neck, you don't puncture it. The only way you can do that is on a living person. So when you're being trained, that's how it goes. The first C-section I did was on a living person. I had never cut somebody before, but I had a senior doctor on the other side of the table. So if there's a problem, they could take over from me. And then I became a senior doctor where I was training persons in the same capacity. So the thing about it is that's how we learn. When you go to places like the university and so, that is the training ground, 10 to 1, you're going to meet some trainee persons. And they're going to have to practice. That's how we learn how to put accesses in people's hands. So more than likely, we're going to damage somebody's hand along the way. Not permanently. Not permanently, because it can repair itself. If it's something complex, we do not allow junior persons to do stuff like that. Now, the thing that happened in Reverend Nichols' case was that her situation was uncommon. It's not necessarily the healing process, it's just uncommon. You do not have those kinds of things happening commonly. So the minute you come in with an uncommon situation, people are going to come to you. The other day, with permission from Bishop Barif, a relative of hers was in the hospital, and he was seen a lot because he had a problem that was also uncommon. You understand? So because you don't see it a lot, more persons are going to come to you. If it's a cough and cold, well, everybody get cough and cold. But if you have Rocky Spot and Mountain Fever, everybody will come and look and say, this is Rocky Spot and Mountain Fever. You may not see it again in your life, but you want to know that the next time somebody comes with it, you know it's Rocky Spotted Mountain Fever. The digital rectal examination is something that all of us have to learn. I found it very unusual that, according to Bishop was assaulted. All right? When I learned how to do it, it was just me and the instructor. He told the others to stand outside the curtain. He just took my hand and said, come, you coming with me. I don't know what I do. So I go with him behind the curtain. He said, me I go do one, and you go do one. I still did not know what I was going to do. He put on a glove, I put on a glove. He went in, and I realized what I was supposed to do, and I went in, and I did exactly what he told me to do, in and out. But he didn't call the rest of the team of persons to come in and go in the same persons in us. So they had to learn on other people. So you go to somebody else and you say, with your permission, you let the patient know what you're going to do, and you do it and you do it and you go until everybody learns how to do it. All right? So I know a lot of people get traumatized, but you can say no. When we are doing exams, we have to use live persons. When I'm doing obstetrics, I have to have a pregnant woman on the bed. They tell me she come in and I have X amount of things to do. I have to put this woman on the bed with her very pregnant self, with her very live baby, and I'm examining and I'm listening and I'm doing this and I'm doing that, and I come out and I have to make a presentation on what I see. What the ladies do, you know, sometimes you touch the belly and the baby stiffen up and you get miserable. When it reaches them, say, not touch me again. And them come off of the bed and come out. I've had a situation. I remember a colleague of mine went behind the curtain, the patient was not there, and the clock starts. An exam she do. Because the woman doesn't say she can't, but she just step off of the ward and not tell nobody she gone. The point I'm making is you have rights, right? But it's just that when you go to these places, you're more likely to be examined. And having said that, if you have an issue, all you have to do is say it. I need to stop now. We're not going to force you to continue. But you just need